Welcome to the lecture on nursing care and management of the shocked patient. So how do we care for patients in shock? Well, it's important to know that you can be caring for a shocked patient in any clinical setting. It is true that they will end up in ICU, but they may initially crash on the ward, so you need to be able to be aware of what shock is and how it manifests and how to care for these patients. So as with the care of any patient in the acute setting, you must perform an A to E assessment. And that's so we have a structured way to assess our patients, so when we're in a stressful situation we can go back to basics. Okay? So always refer to your ADS chart when you're working on the wards and you identifying deterioration in your patients. The ADS chart is very simple and it tells you what to do according to the ADS score. Okay. So once we've identified from the ADS chart that we do have a shocked patient, we need to do our A to E assessment. We need to support our patients, and that support it's physical, it's emotional, and it's psychological as well. These patients are sick, they're going to be anxious, they're not going to be feeling so good. And we need to think about the family as well. Especially if there's family present in the room while the patient is deteriorating, we may need to remove them from the situation or talk them through what's happening if they want to stay. So communication is very important, and that's with the patient themselves, the staff and the family. Okay, so often when we have a deteriorating patient, the team of medical professionals, nurses, all stand around and talk over the patient. I see this very often, and it's very important to talk to the patient, explain what's going on. It's going to reassure them and keep them calm. Okay. Staff also need to communicate well together. As a team of people may be working on a patient and doing a number of different things at a time, there needs to be clear communication as to who's doing what, and preferably have roles assigned and have a team leader. So as far as interventions go, we'll have a nurse doing observations usually, one probably administering some fluids, a scribe, there'll be medications that are ordered and administered, and then we'd need to prepare our patient for transfer up to ICU if need be. So in our patient assessment, as well as the A to E assessment, we need to be carrying out a cardiovascular assessment as well, a respiratory assessment, a neurological assessment. We need to be assessing renal function on our patients. So a fluid balance chart is essential, and it's essential to keep that up to date so we can monitor how much fluid the patient has had, especially in the preceding few days if they've been in hospital a few days. So observations we'd be doing on our patients are the standard observations. There's nothing flash, so we'd be looking at our patient's respiratory rate, the temperature, do they have a fever? Is it septic shock that's happening? What's the heart rate like? Is it elevated? The blood pressure, are they hypertensive? What are the oxygen saturations and the urine output? And we'd be assessing the GCS as well. So we need to be doing regular observations, and how regular? It depends on the patient, depends how sick they are, how rapidly they are deteriorating, and the ADS chart will guide you. But if we have someone in a met call situation, we would be doing constant observations. If we've got someone who's very sick and needs a close eye kept on them, it could be every 15 minutes. In an ICU environment, we have patients connected to the monitor and they have constant observations done, and we record them hourly. So the constant observations that are done in ICU, we monitor the heart rate by a cardiac monitoring, and the blood pressure via arterial line monitoring. And this is what an arterial line would look like, and most patients have these in ICU. So as you can see, there's a cannula that goes into the artery here. It's usually the radial artery, but you can also have a femoral one as well. Now this it's connected to a transducer, a bag up here, has a transducer, and that goes to the monitor. And this will monitor the pressure, gives us a constant blood pressure reading. And as you can see from this image, here we have a little port, and that's where we can access bloods. So we can take frequent arterial blood gases without stabbing the patient every time. And they would be able to monitor the lactate, the usinase, we'd be able to monitor the creatinine from the arterial blood gas, as well as various number of electrolytes, and the pH as well, obviously. So it's very important with our patients that when we identify the cause of shock and we treat that cause. If we don't treat the cause, then the patient can deteriorate quickly. So just another thing to mention, that our patients in ICU will often have a central line as well, and with the central line we can monitor their cardiac output, and we can also measure their fluid status as well. So as we said, it's important to identify the type of shock in order to treat it correctly. So it's important to get a very thorough past medical history on our patients. What's happening? What brought them here? Have they been in hospital a few days and deteriorated? If so, how? Is it trauma? If it's trauma, we treat the shock as hypovolemic until proven otherwise, and we need to find the source of bleeding. Remembering that our patients can have internal bleeding as well, and they can lose a massive amount of blood in the thoracic cavity, the abdominal cavity, the pelvic cavity, and in the long bones. And then we can consider other types of shock based on the clinical findings that we'll come across. So if we have a patient with hypovolemic shock, we need to stop the fluid loss. Obviously we need to secure the airway and breathing first, but we do need to stop that fluid loss. So if someone's bleeding, we need to apply pressure to the wound. Then we need to think about getting access. We need 2 large bore IV cannulas, and we need to start replacing the fluid that's been lost. And depending on what's caused the hypovolemic shock, it could be crystalloids, colloids, blood or plasma, and that's going to be to maintain an adequate systolic blood pressure or mean arterial pressure. We're going to need to keep our patients warm as well, and we may need to prepare them for emergency theatre or transfer to ICU. So when caring for our patients with cardiogenic shock, it certainly requires a complex multi-system approach. So frequent assessment of the condition and treatments would be required. These patients would be in an intensive care unit or on the coronary care unit, and their heart rate and blood pressure would be constantly monitored. We'd need to do frequent ECGs as well, and troponins as well, to assess the level of cardiac muscle damage. So patients with cardiogenic shock, we need to really increase that oxygen supply. We can do this by a number of different ways. We can position our patient, and we can administer CPAP or BiPAP as required. We need to decrease the physical activity. They would be on bed rest. And we need to provide holistic care and support to our patients. Now, when it comes to fluids, we need to really carefully assess patients in cardiogenic shock, because they do tend to have adequate circulatory volume because they haven't lost volume, and we could easily overload them, and that could lead to pulmonary edema, which could cause our patients to deteriorate further. These patients in cardiogenic shock are usually on high-dose inotropes. And that's because inotropes promote myocardial contractility, which improves cardiac output and obviously blood pressure. So inotropes, they must be given centrally. So the patient will need a central line and also need continuous blood pressure monitoring via an arterial line. So these patients will be in ICU. And just to clarify, when I say that inotropes must be given centrally, it means that they must go into a large vein, which is usually the internal jugular, but can also be the subclavian and the femoral as well. So these are a number of different inotropes and their actions. This is a great table of the most common inotropes used. There's a lot of information in here, which I suggest you read through in your own time. But adrenaline and noradrenaline are the most common to be administered in the intensive care unit. And often we can have patients having a number of different infusions. They can be on 2-3 different types of inotropes depending on what's wrong with them. So let's have a look at the nursing practice around anaphylaxis. Okay, so again, where our assessment goes is we need an accurate history of our patient. What happened? What was the allergen that they came into contact with? Do they have any known allergies, or is this their first presentation? And when did their reaction start? Then we need to perform an A to E assessment. We need to remove the causative agent as well. Now, very important to secure our patient's airway early with anaphylaxis, because they can get that laryngeal edema and their airway can close over very quickly. And we'd need to prepare some IM adrenaline or IV if we have IV access. So we would need to intubate them early, as I've just stated. And then we'd also need to administer antihistamines and corticosteroids as well as adrenaline. So the nursing practice for caring for patients with sepsis is very similar to caring for patients with hypovolemia, and involves the thorough assessment of our patient, correct any physiological deterioration and fluid management, and address any underlying infection. And we usually do that with broad spectrum antibiotics until the results of a septic screen have come back. So a septic screen usually involves taking a number of samples and sending them to the lab. So we can have a urine sample, a sputum sample, and blood cultures as well. These are usually the standard that we would send off to identify the source of infection. So our patients with sepsis may also be administered vasopressin, which is a type of inotrope. So remember, our patients with sepsis would have this widespread vasodilation. Well, vasopressin works by squeezing all the peripheral vessels, which increases the systemic vascular resistance, and that would increase blood pressure. So having to think about the nursing practice for our patients in neurogenic shock. A to E assessment again. I've missed D and E off here. And we need to stabilise the neck and the torso as well, because usually these patients have neurogenic shock as a result of some kind of spinal trauma. So we need to consider fluids cautiously, depending on the clinical presentation. We also need to do a respiratory assessment and monitor, because there may be a risk of pneumonia and atelectasis as well. So we need to maintain the core temperature. They may be hypothermic, so we can maintain the core temperature usually by putting a bear hugger on them in the critical care area, and the bear hugger works by is a blanket that you put over your patient, and heat is administered through there, and it maintains the core temperature of our patients. We would keep our patients with neurogenic shock nil by mouth, and it's very important to maintain impeccable pressure area care for these patients, as they would be on spinal precautions and need log rolling regularly. So once we've carried out our primary survey, we need to move on to our secondary survey. So a secondary survey means a more in-depth survey than what we've already done in our A to E assessment. So that includes a top-to-toe assessment, literally from the scalp down to the toes. We need to carry out a thorough assessment to see if we can identify any potential injuries or symptoms that we haven't already identified. And we need to continue the assessments that we've already started. So we're continuously assessing our A to E, and we're continually doing our observations as well. Depending on where you are, if you're in ICU, they would be continuous anyway. So further assessments we can do cardiovascular assessments, respiratory and neuro assessments. And we certainly do these every 4 hours on all of our ICU patients anyway. So as part of your secondary survey, you are documenting everything that you're doing and administering the medications as prescribed by the doctor, and fluid management. And this includes not only administering fluids, but documenting output accurately as well, with a fluid balance chart. So the treatment pathways that our shocked patients can have. So once we've stabilised our patients, obviously the fluid rhesus would be ongoing for a while, depending on what's wrong with them. Medication management. Medications can be complex in the shocked patients. It does depend on the type of shock, but there'd be a multitude of medications that our patients are on. They may be on constant infusions, oral tablets, IV tablets. There may be a number of different pathways, and the care for these patients is usually complex. They may need theatre. And often patients suffering from shock, whatever type of shock it is, they're usually in hospital for a number of weeks, and they would need ongoing rehabilitation following this, because they can become very weak. Most of the patients will be transferred into intensive care, coronary care, or a specialist spinal unit. So it can be quite hard to think critically under pressure, which is why it's so important to maintain a systematic approach to your patient's care, so you're repeatedly doing the same thing every time so you don't miss anything. Remember your ABCs and your A to E assessment. There can also be a number of different causes for the shock and different combinations of the shock. And it's important to get your head around the fact that we may need to restrict fluids with our patients in shock, even though they're hypovolemic. It can be really easy to overload our patients and send them into pulmonary edema, which can kill them if not treated effectively. So we need to be very, very careful and cautious when administering fluids. So we need to make informed decisions, and that's by using a systematic approach to their care. And we must also make sure that the care we are providing is holistic. We're remembering the person as a person and not a group of symptoms put together. We need to be talking to them, communicating with them, reassuring them, communicating with their family as well. And remember essential nursing care, such as personal hygiene, pressure area care. So thank you very much for listening. I know this was quite a long lecture. There's a list of references here, and please feel free to go back and listen to segments of this lecture as need be and read through the lecture slides. Thank you for listening.